So welcome, everyone. This is a very exciting day for us here at Virginia Early Intervention Professional Development Center because this is our very first ElevatED EI workshop. And we are excited to kick off this new professional development learning method and opportunity for our Virginia Early Intervention professionals. Today, we're really thrilled to welcome so many from Virginia and also from, we have all corners of Virginia represented, and then also we're bringing together folks from across the United States who are all focused on birth to 3 and supporting families in their journey of parenting and supporting their children's development. And as I said, today marks that very first launch of ElevatED EI. And for us, this is an opportunity to really be able to go deeper than we are able to do in some of our other offerings, like Talks on Tuesdays that you might be familiar with, or SC Chats, which are really, our wonderful 1 hour webinars or communities of practice. But here we have the opportunity to really, with these 3 hours, really be able to go further in our learning together. So let's go ahead and kick off today's workshop. So here's an overview for today's session. We're going to do our introductions, and then we're going to, I'm just going to show you how what we're doing today aligns with the professional competencies that we're all, each of us uses to improve our practice and do the best that we can for children's families and our teams. And then we're going to dig into part 1 of our workshop. That's when I'll turn it over to our presenter that I'll introduce in a moment. We'll have a 15-minute break around 9 or 9:15, 10 or 10:15, whenever Sharon's ready to close out part 1. That'll be a little flexible, and then we'll start part 2. At the end of each session and throughout, Sharon will let you know when there'll be opportunities to ask those questions, and feel free to always post questions in the chat. We're here to help make sure those get to Sharon too. And then we'll just do some closing and housekeeping on things like surveys and evaluations and certificates for your professional development hours. I did want to introduce now our a team of folks who have been working hard behind the scenes to bring this topic to you. So you've got myself and Morgan Colleton, who are members of the Virginia Early Intervention Professional Development Center. So we have been representing VEIPD in this work to develop this workshop for you all. And we've been joined by Lisa Denny from Early Impact Virginia. She is their workforce development specialist, but I'm going to give her an opportunity later on to be able to give you a little bit more background on Lisa as well. We do have a landing page that has all of our bios on there if you'd like to kind of learn more about who these people are who have been doing some of the behind the scenes work. But this really is a wonderful collaboration today between Virginia Early Intervention and Virginia Home Visiting. So that's what we're bringing together by working together across this kind of home visiting, those who are in-home sector in Virginia. And then we have the amazing Cheryl Hesseltine. Sharon is joining us from the Opioid Response Network. And again, I'm going to let Sharon give you all of her background, or as much as she can. Sharon has a very, she's not only knowledgeable, but she's absolutely authentic in this work. She's been doing this work for many years, has been on the ground floor, and has continued refining her knowledge and finding different ways to impact the field and help the field build the skills they need to be really impactful in their work with homes. And I just want to acknowledge too that as you see this team up here, we've been behind the scenes, as I said, working to bring this to you. However, this topic really arose from you all, from our, so it's a grassroots need that we heard through different voices across the state. And so we started, kind of tracing those conversations and finding out what the exact needs really were, and then trying to sequence and develop something that we're hopeful, again, will help help you in your everyday work with families who may be experiencing substance use disorder, and then also just understanding how to navigate some of those conversations with families, just even around substance use and safe storage and things like that. So I just wanted to recognize that as I showed who was and who has been a partner in getting this kicked off for everyone. And I just also mentioned earlier that this workshop today is aligned with our different professional competencies and all the ways that we're trying to grow as professionals. You guys have the PowerPoint slides. They'll also be posted on our landing page on our website, Virginia Early Intervention Professional Development Center, as well as the Opioid Response Network's website. We'll make sure everybody has that. So I'm not going to read through these, but I just want you all to recognize and see how today's workshop is really supportive of growth across the field and birth to 3 work. So we have the Division for Early Childhood, really focusing on that family strand. For service coordinators, the family-centered practices strand. And then also in Virginia, and then I know in other states as well, in early intervention, we are working to really expand our use of the pyramid model framework. And so this workshop today is aligned and supports your work in the building partnerships with families key practice. And then lastly, that we're highlighting here, but not lastly overall, we do have alignment with the infant mental health competency guidelines, and specifically here for the infant family specialist. So again, if for whichever bucket you might fall in or dip from multiple ones, just know that those are here for you to be able to take a look at. Oops, sorry about that, guys. So I'm going to go ahead and stop my sharing and turn everybody over to the actual person here who's here to really get us going and learning. So I'm going to stop sharing. And then Sharon, I'll turn the controls over to you to let everybody know more about you. And started.
Thank you so much, Lorelei. It is really just a great pleasure and honor to be able to be here with all of you today and folks at early intervention and home visiting, because this is where my roots really are. So I come to the work that I do both from my professional experience, my educational experience, as well as my lived experience. So I have educationally, my background is both social work and infant mental health. I got to complete a 2-year postgraduate certificate in infant mental health at the University of Minnesota well into my career. So I got to go back to school at a much later date in infant mental health, which was amazing. My work experience really is grounded in evidence-based home visiting, both at the local level in the very southernmost part of the state of Illinois, and then for the state worked for the state health department for the state of Minnesota. At the time that we were so blessed, and I gotta say, just like something I thought would never happen in my wildest dreams was federal funding for home visiting and so on. But in the course of all of that, I started my work as a home visitor with pregnant and parenting adolescents, and then ran home visiting programs for, including early Head Start, for 17 years, and then ended up working for the state in Minnesota. So, and I am, I thought debated whether to tell you all this at the beginning of the presentation or at the end, but I'm just going to tell you at the beginning, I'm also a person in long-term recovery. So for me, that means that I have not misused substances for over 20 years. And I do, within some of this presentation, use some examples from my lived experience to illustrate different points. So just kind of to let you know that on the front end. So this work is really my passion. And I also had opportunity to do quite a bit of work in early intervention, actually. In the early 90s, Illinois did system redesign for early intervention, and our health department was responsible for our southern 15 counties of Illinois local interagency council and a lot of the advocacy work and supporting parents. And I had the gift of being in the role of the person who was doing that. We were one of 3 pilot sites for the state of Illinois, piloting a system as it was being developed. So it's pretty cool to get to do all of those things. One thing I learned is if you work in local public health for a long time, you get to do a little bit of all kinds of different things. And you just never know how that's going to benefit you later. Let's see. You all should now be seeing. I bet you're not, though. Let's see.
We
Now
can see
you
it.
are, right?
Now we see your speaker notes.
I don't know why it's acting differently than it did. Let me try it again. All right, you all seeing the full screen now?
Yep.
For a second there, it was acting different than it normally does. It's like, that always throws me when it does something different for unknown reasons. As Lorelei said, I work with the Opioid Response Network. And just so you all know, we are funded through the Substance Abuse and Mental Health Services Administration. And we are funded to respond to training and technical assistance requests that can really come from a wide range of entities, all the way from state governments to local nonprofits, faith-based organizations, for-profit organizations, kind of across the board. And we're able to provide training around anything across prevention, harm reduction, treatment, and recovery. And everything that we do is grant funded, so it's at no cost to those who are requesting training or technical assistance. So if you find right through this training, you're learning about things that you want to learn more about, that you'd like to go deeper on, we've got a really robust array of trainers and presenters and consultants all across the country. We do things virtually, we do things in person, and so on. So we're just, I think, an amazing resource, and we are just been refunded for the next 3 years. Yay. So we're not going anywhere anytime soon. This is one of the ways that SAMHSA supports the behavioral health field. So, and how the way that you connect to us is through our website, which is the opioidresponsenetwork.org. And if you go to, thanks, Debbie's put the link into the chat. If you go to our website, then what you'll find is, sorry, I have a dog that was insisting on getting into the trash can and I had to move it. The up in the upper right hand corner of our landing page, there's a link that says submit a request. And you basically fill out a little Google form that takes about 5 minutes, and then one of our staff that work with Debbie will get back to you within 1 business day and set up a Zoom with you to talk about what you're looking for. And what I always like to let folks know is that they don't need to know exactly what the TA needs to look like. I always ask folks to just think about, is there something that you want to look different in your organization or in your services, or something new you want to provide or have a greater understanding of? And then we really work with you to design technical assistance or training to meet your needs that's individualized. So, and that's how this all came to be today. So if you want to know how easy the process works, ask Lorelei and she will definitely be able to tell you. So what I want to try and take a look at today, and I will say I'm sure that I will go all the way to 10:15, is really one, I'm just going to start kind of briefly, just getting us kind of centered and I think grounded around what do we mean when we say the word recovery, and just our concept of what that is. Because I think in a lot of ways it's evolved and it's changed. And so it's really helpful to think about that when we're talking about supporting parents who are either on the journey in recovery, looking for recovery, haven't even thought about recovery, kind of what does all that mean and what do we mean when we even say that word. Where I'm going to spend most of my time in this session is really about how we understand addiction as a chronic brain disease and what that means. Because here's like what I know is that when we are working with someone who is active in this disease of addiction, it is really hard. It's a tough population. We have children involved. It can be really challenging and stressful and worrisome. And so I really want to help support you all in understanding why does it look the way it does? Because from the outside looking at folks, it looks like they're making a choice. And what I want to share in this section is how the brain is impacted. And the way that I always say it is when the brain becomes an addicted brain and what changes are there. And also it has some implications for practice. So as people move into recovery, right, how we support them and how we understand what we see and what we don't see is influenced by the way that the brain's been affected by the disease. So I'll spend most of my time there, really touch very briefly on the connection between ACEs and vulnerability for addiction. I will make what I think is a relatively safe assumption is that most, if not all of you, have had other training that really cover what adverse childhood experiences are and so on, but we want to think about kind of where do they fit within this larger puzzle of addiction, and then looking at some of the challenges that are faced when parenting and early recovery coincide. So I'll start with just conceptualizing recovery, because the reality is that addiction in its active stage is very visible. Recovery, on the other hand, is pretty invisible. And I always am reminded that if I never said to folks that I was in long-term recovery, they wouldn't know. So part of why I share that is, one, I do like to use some things that have happened in my life to illustrate some key points that can be hard to conceptualize. But the other piece is that I believe really strongly that if we want to help folks recognize that recovery is truly possible, then people in recovery need to, as we say, recover out loud and be open about that. Because, and as I'll share, this is a disease that really 85% of the people who use a substance, that changes how they feel, and I include alcohol in that bucket. 85% of folks will never develop this disease. And so the 15% that do didn't necessarily do something wrong, bad, or different than the 85% who didn't. And so we'll take a look at that. But about 50% of the folks who at one point met diagnostic criteria by the diagnostic criteria within the DSM, the Diagnostics and Statistical Manual, who met that criteria for substance use disorder, and this is like 25 million people, are in stable remission. And so we think about remission of the active symptoms and remission from meeting diagnostic criteria for a year or longer. And when we think about the term recovery, because we think about both recovery and remission is really about the absence of symptoms, meeting diagnostic criteria. But recovery goes beyond just that remission of symptoms and really includes positive changes in the whole person and a continued process of growth and promotion of health and wellness. There's all kinds of discussion, and we hear a lot about a term called harm reduction, and some of that comes from the probably ongoing debate in certain circles of whether abstinence from every substance is actually necessary, and that it's really more of an emerging area, and it's for folks, and particularly for folks who meet diagnostic criteria for substance use disorder severe, abstinence may very well be necessary, but that is not always the case for every single person. And abstinence from all substances is not sufficient to define recovery. So we'll look at that a little bit more closely. Historically, when we use the word recovery, we think about people who are engaged in 12-step programs, and the ones that we hear about most frequently and folks are most familiar with would be Alcoholics Anonymous or Narcotics Anonymous. And there is some evidence that demonstrates that those programs do work and do help folks. They are not a fit for everybody. And it's always important that we remember that while those programs may be helpful, they are not treatment, right? Because treatment is a professional approach, right, to putting the disease into remission. So 12-step programs really fall within the arena of mutual support in the community. They do help folks grow some of the active ingredients necessary for long-term remission and stable remission and recovery. But they won't be a match for every single person, nor is participation in a 12-step program the absolute barometer, be all, end all of an individual's capacity for or likelihood of achieving recovery. So, and there is also really growing evidence for the effectiveness of other kinds of broader recovery supports, and that may be collegiate recovery programs, it may be recovery housing, recovery ready employers. There's a lot that's been going on across the country about really broadening our community recovery support. So the Substance Abuse and Mental Health Services Administration has this definition of recovery, which was established in 2012 and stands today. They did revisit it pretty recently. And they really defined it as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And there's, I feel like I kind of have a love, not so much love relationship with this definition. I love it because it is broad. It is all encompassing. It includes mental illness as well as substance use disorder. And you're right, it's very inclusive. Lots of folks could say that they're trying to improve their health and wellness. If you've ever tried to eat healthier, exercise, right, meditate, any positive change in your life that improves your health and wellness, and you like to live a self-directed life and you're always working towards personal growth and reaching your full potential, you would fall under this definition. And I think that's many of us that do so. I think the challenge with it is it's not measurable. And it doesn't lead us to anything that says this is what is considered a successful outcome that we can measure. And so I think that makes it challenging in our field around evidence-based approaches and so on. So, and the substance use disorder treatment field and recovery support services is really going through a lot of shifting and changes and expanding right now as we begin to think about models of support and models of treatment that go beyond abstinence or nothing. For such a long time in the field of substance use disorder treatment, it was really a one-size-fits-all approach. If you wanted to do something about your substance use and it looked different, that thing would be abstinence from all substances, and there was no other options, support, and really attention to developing an evidence base around anything else. And that's really changed probably, I think, in the last 5 to 10 years. So this slide was developed by Dr. John Kelly. Dr. Kelly is the director of Recovery Research Institute. And Deb, maybe you can throw the link for Recovery Research Institute into the chat here as I'm talking. Dr. Kelly really is kind of the leading national researcher around recovery. And actually over this last month, all through September, which was Recovery Month, they posted lots of really great things about what we know about recovery and what research has shown us. Dr. Kelly is also a professor of psychiatry at Harvard, and he's also a person in long-term recovery himself. So I always feel like he's a pretty smart guy, and he focuses on this. And I got to hear him speak a couple of years ago, and this for me was just kind of really blew my mind. And I think it gives us great context. So when you look at the left side of the slide, what you see is this recovery priming. So you look at this first third of this slide on the left-hand side, and it really is that period of time from when a person meets the diagnostic criteria for addiction and when they may seek help, and concrete help, whether that may be, as he defines it, entering a formal treatment program or really getting engaged in any kind of mutual support within the community in a robust kind of way. That is, support, that mutual support that's designed to help folks around addiction. And I'm going to skip a couple slides and then I'm going to come back because what I want us to remember is when we talk about addiction, when I use the term addiction, I'm talking about a substance use disorder where an individual meets diagnostic criteria at the severe end of this disease. So, right, lots and lots of folks use substances that change how they feel. Like most people do. Right, better than 50% of the population, adult population, has used something at one point in time that changes how they feel. And again, I include alcohol in that bucket. And then we think about substance misuse, where somebody's use is maybe they took a prescription that wasn't theirs. Maybe this is the thing that always blows people's minds. If you've received a prescription for pain, let's say for dental work, and don't take them all because you don't like that stuff, and you have them in your bathroom, and 6 months later you injure yourself. Let's say you throw your back out and you can't move and you can't sleep, and like, oh, I got some of those pain relievers left over from my dental work. I think I'll take one. That actually meets the definition of substance misuse because you're taking a prescription for something other than where it was prescribed. It doesn't mean that you have a problem with substances. It just falls under that category of misuse. A person who drank more than 3 drinks of an evening for, 3 drinks of an evening for a female, 4 drinks of an evening for a male, that's substance misuse. So, right, a lot of people fall in that category, but it doesn't mean they have a substance use disorder. When we think about what substance use disorder, it can be diagnosed at the mild, moderate, or severe stage. And it has to do with how many of the 11 diagnostic criteria that are listed in the DSM. And so as we get into some of this stuff, what I want us to remember is we're talking about
150 people. Oops.
Substance use disorder, severe, and pretty specifically. So back to this slide, right? At the very beginning, right, folks oftentimes are in that stage of a substance use disorder, severe, or addiction for a period of 4 to 5 years before they really initiate very concrete and kind of robust attempts at recovery. And then run in the middle of this timeline, what we see is on average, individuals may have between 4 and 5 episodes of engaging in treatment services. He calls this, right, recovery mentoring, or 4 or 5 engagements. And again, pretty robust engagements in participation in mutual support groups and being really involved in those kinds of things over a period of 8 years prior to being able to hit 5 years of continuous recovery. And what's magic about 5 years of continuous recovery is it's at that 5-year mark where an individual's risk of being in active addiction or right, meeting that diagnostic criteria for substance use disorder severe, where that risk drops down to 15%, and where they're pretty close to on par with the general population. Now, an individual who's had addiction is always going to be more vulnerable to be active in that disease than someone who's never had it at all. That's consistent with every other chronic disease. But we're really talking about a period from the point in time someone meets criteria for addiction to being able to get to 5 years of continuous recovery. We're talking about a 12-year period of time. And the reason I share this, and I think because this is a broader context of this, is that we wonder, one, why do people keep recycling through? One, right, this is a chronic disease. And so with every chronic disease, there are periods of recurrence and reactivation of that disease process. This is also a disease where the system and the approaches to treating it fall far short of what individuals really need and would most benefit from to achieve wellness. And what I want you to do is to kind of think about, if I just will parallel it with diabetes, like if you could imagine if someone developed type 2 diabetes, and their treatment looked like seeing the doctor, having visits maybe once a week or so for about a month, getting a little bit of nutritional counseling and getting a prescription, and then never getting any medical care after that. Imagine what that outcome for type 2 diabetes would look like without the ongoing medical management. Folks would end up in emergency rooms far more often. Folks would have a much more difficult time controlling their blood sugar, right? Being healthy and keeping those active symptoms in remission. And with substance use, the way the system looks right now is that for many folks, if they're able to access treatment, one at all, it's not always at the level that the disease progression would indicate. I happen to be married to somebody who works on the treatment side of this world, and who will say over and over again, it is very rare to get authorization for the level of care and the length of time that the person would most benefit from, based on evidence-based assessment and diagnostic criteria. So we think about, why do people keep revolving, or we think about people failing at treatment, or treatment doesn't work. The biggest factor around that is that there's not the ongoing support on a systematic, accessible level that folks would really most benefit from to have the greatest opportunity for long-term recovery. And that's challenging. And it doesn't mean people need residential treatment for 5 years, but folks need ongoing recovery support services and management of a disease. And then when we think about what are the active ingredients that are necessary for sustained remission and long-term recovery, from Dr. Kelly's work, that this is what they've really identified. And it goes by this acronym CHIME. And we say is connections, hope and optimism, identity, being right, a positive self-identity, meaning and purpose, and empowerment, right? And there's a lot of different ways that folks can grow these active ingredients. So we think about the work that you all do in early intervention and in home visiting, and what where you fall in is, right, we're building connection because we're building relationship with folks. We are helping strengthen parent-child relationships, which is vitally important and critical. And as I'll talk about here in a little bit, actually helps the brain recalibrate, which always blows my mind. One of my favorite things, right? Meaning and purpose. Lots of folks find a lot of meaning and purpose in their role as a parent. This particular population of folks with substance use disorder, and you all, I'm sure, have seen this, feel horrible about themselves as a parent. If you are in a situation where your active substance use disorder crossed over the period when you were pregnant, you feel, I think it's like the lowest of low. Again, as a person, I've been in recovery for 20 years. The only place related to my active addiction that I still feel guilt around is not being able to show up as the parent that I wanted to be and the parent that my daughter deserved. And it made a lot of peace with it, but it's never gone away, and it probably won't ever completely go away. And part of what I get to do in my work with ORN is I train a lot of folks with lived experience, and I know that I hear the same thing from them over and over again, right? And then this last one is empowerment. So Danny, I see your question by saying it's similar to the concept of relapse as a part of recovery. This is how I look at it. What I look at it is, one, I'll try and stay away from the word relapse, only because it's kind of gotten to be like the synonym for failure, right? And what I want us to do, and I'll challenge you all to do this, is we want to kind of tease apart a little bit the returning to use, all right, versus reactivation of the disease of addiction. So let's say, all right, a person has been through treatment programming and they're not using, let's say their choice is, and they're working to not use any substances. And then they do, right, return to use, right, pick up a substance. They may or may not end up meeting diagnostic criteria for addiction again. Does the returning to use increase the risk of meeting that diagnostic criteria? It does. But not everybody will end up meeting diagnostic criteria. There are some people, for example, and I have seen this, folks who've had an opioid use disorder who use cannabis or use alcohol don't meet any diagnostic criteria at all around that substance, nor do they end up returning to opioid use. That does happen. And I think it probably happens more often than we may realize because folks don't talk about it. But reactivation of the disease, right, means meeting diagnostic criteria. So again, I like to kind of separate that. And I always think about, right, part of this, I think, is just my preferences. I think about return to use for some folks could be a part of the disease process versus a part of recovery. So again, there's a difference between, right, using a substance again and getting to where you're meeting the diagnostic criteria again, because the diagnostic criteria is not whether or not you use the substance. It really is what happens in your life as a result of your use. So I hope that helps Danny and doesn't totally confuse the issue further. But it's a really important thing to think about because so frequently the barometer of success is whether someone has used a substance at all or not. And the reality is, when we're working with families where substance use disorder has been an issue, where we have had infants that have been born, that have been impacted or affected by substances, we typically will have child welfare involvement. And without a doubt, when child welfare is involved in the lives of families with substance use disorder, they frequently are going to require complete abstinence in order for folks to either retain or regain custody of their children. And that's part of, right, an individual's reality when child welfare is involved in their life. And I think what I would say around that is if an individual is really struggling to not use a substance, even when the consequence of using that is losing custody of their child, then the use of the substance is definitely getting in the way of things that matter in their life, which would be raising their kids. So it's nuanced, that is for sure. So let's talk a little bit about, right, addiction as a disease and kind of, right, what happens. Because what I want y'all to understand, and I hope if you don't leave this with any other thing, that one of the things you leave with is the consideration that for someone who, again, whose brain has become an addicted brain, that the actual use of substances isn't quite the choice that may appear to be. And that's what I really want to unpack in this next section. And it's a hard one because this is a disease that affects our brain. And so I think about the reality and the fact that 85% of folks that use substances will never develop addiction. So most people don't. For most people, it's always a choice whether they're going to use a substance or not. And I always think about, right, our own human experience and our own human experience with our own brain. And what I think is that my day-to-day experience with my brain is that I'm in charge and I'm making decisions. I mean, I'm deciding to share information with you. That's a conscious decision. I'm being, right, conscious and deliberate in the language that I use and all of those things that make, right, I feel like I'm in control. At the same time, the majority of the stuff my brain is doing, I am not controlling. right? I can, say to myself, oh, right, lift your left arm, and I can lift my left arm, left foot, whatever. But I can't say to myself, hold your breath for the next 30 minutes. My brain is going to make me breathe. Like, I can't do that, right? I can't consciously do that. I can't consciously slow my heart rate down to 40 beats a minute just by deciding that that's what, right, I want to do. So, right, there's a lot that's going on physiologically in our brain that we are not in control of. There's things going on emotionally related to our brains that we are not in control of. Now, I love to use this definition from the American Society of Addiction Medicine of what addiction is, and I like it for a variety of reasons. One, it starts out that this is treatable. This is a treatable chronic medical disease, and it reminds us that this involves some pretty complex interactions that are among brain circuits, genetics, the environment, and an individual's life experiences. And then what it looks like. It looks like folks use substances in a manner that's compulsive, and that they can't stop themselves, and that it continues even when there are really significant harmful consequences in their life and what is going on around them as a result of that. And also, I will add, right, folks have an inability to put those pieces of that together and really see how harmful those consequences are. And people have a really difficult time making the connection that it's the use of substances that's the causing the harmful consequences. And as I get into the brain changes, we start to see why folks have a difficult time. This definition also reminds us that prevention efforts as well as treatment approaches for addiction are generally as successful as they are for other chronic diseases. So, and if we look at other chronic diseases and we compare it to addiction, kind of the cycles of, right, recurrence, which is again reactivation of the symptoms of the disease, and cycles of remission. With addiction, it's pretty similar to every other chronic disease that we would treat, which to me is actually remarkable because we don't have the ongoing management and support services in a systematic way for addiction in the same way that we do for diabetes, hypertension, and asthma. So I always wonder, like, what would this look like if we had a system of care that was really, truly, truly research informed, and offered folks extended supports and recovery management over a period of time. So when we think about, right, what addiction is not, and I love to kind of, I love to step back and think about this, particularly, we think about this first bullet, right? So frequently, and I hear this said all the time. Well, everybody who has addiction just has untreated trauma and they were self-medicating, and this is how this happened. And so addiction really is untreated trauma. And what we want to remember is addiction is its own disease process, but certain things increase vulnerability to be one of the 15% of folks that would develop this disease. And mental illness is certainly one of those things. Trauma history is another one of those things. Those things do contribute to the vulnerability, but in and of themselves, they are not the cause. I also think that it's important to know that lack of social connection or isolation is not the cause. Facebook in its infinite wisdom, right, has somehow discovered I have an interest in addiction. Don't know how that happened. And I get this clickbait periodically that says, now we know the real cause of addiction, and it's not what you think. And I'm always like, oh, it's not what I think. What is it? And it's always the same thing. It's this TED Talk where this guy is talking about it's caused by a lack of social connection. And the research that's often cited to prove this point is a rat park research where they have rats who are, right, socially isolated versus the rats that are connected and living in community. And the socially isolated rats are far more likely to push the lever for cocaine than the connected rats are. To extrapolate that and say, social isolation or lack of connection is the cause is a big leap. Connection is one of the active ingredients necessary for long-term recovery. It's not that it's not a factor, it's just that it's not the cause. Because if it was the cause, y'all, we wouldn't be here. It would be so much easier to help folks. We just help folks get connected. And then they would be well, and they wouldn't have any recurrence, and we wouldn't need to do all the things that we do. It's also not a moral or an ethical problem that folks don't develop addiction because they make bad decisions, do bad things. And I hear people who are in long-term recovery said, I made bad decisions. And I'm always thinking, like, 85% of the people who made the same decision you made didn't end up where you ended up. Now, many folks in their active addiction will do things that totally contradict their own values and morals and their own ethics. I certainly did. And that can feed a lot of shame and a lot of guilt. And like I say frequently, right, active addiction really gets in the way of folks being the parent that they want to be able to be, because of how this disease impacts the brain, and particularly in its active state. It certainly did for me. That went against my values in a major way because I wasn't showing up as the parent, as the type of parent that I wanted to be. And I wasn't showing up in a way as a parent that fit with my value system. And it was created a tremendous amount of guilt and a tremendous amount of shame that has to get worked on right later on. Addiction is also not casual use, right? There is a compulsion to seek and use the drug that is like unparalleled, and individuals lost control completely in limiting their intake. And that's in every single instance of use. So that's also really different than somebody who just kind of drank too much one night. This is like an ongoing every time thing. And at the same time, the individual, as they're developing addiction, their ability to recognize the significant problems in their life is diminished because of how the brain is changed and impacted. A significant negative emotional state emerges. There's a lot of craving. Craving is really, the word craving gets used all over the place. I think particularly in the food industry, and in a lot of advertising, but this is a level of craving. One, it comes from a part of the brain called the amygdala that we don't have conscious control over. I can't, right? If I experience craving, I can't think it away. Now, my great gift in long-term recovery is as long as I don't, for me, pick up a substance, I don't experience craving. But what I do know is if I were to pick up a substance, I'm pretty sure it would come right back. And that's kind of for me where I tend to operate from. It's chronic, and there's those periods of remission and recurrence. And I think about, Danny, as far as like when there's a side effect to these things than a cause, what I like to do is I think about them more as things that contribute to the vulnerability. So if we take, I sometimes like to talk about the brain as if I've like pulled it out of my head and I'm sitting it in my hand, separate from the body. And I think about, okay, what are the things that make a brain more vulnerable to becoming an addicted brain? Right? Because again, I keep going back to, right, the vast majority of folks that use substances, this never happens to them. So it's kind of like, so why does it happen to some people? And it's that combination of vulnerabilities, right? So that co-occurring mental illness, trauma history, genetics, environment, right? All of those things contribute to that brain maybe being more vulnerable, right? Than another brain. So, and part of what can also contribute to vulnerability is the age at first use. So, right, the adolescent brain, because adolescent brain is still under construction and under development, tends to be more vulnerable to these changes as well. So I'm going to share a video with you all. It comes from an organization called the Addiction Policy Forum. It just does a really nice job of explaining kind of how some of the ways in which the brain is impacted. So it's relatively short and really nicely done. So I'll let this roll.
What is addiction? It's also called a substance use disorder. Over 20 million people nationwide suffer from addiction. 1 in 7 people will experience addiction at some point in their life. Scientists first began to understand addiction as a brain disorder back in the 1950s. Doctors Olds and Milner, in laboratory studies of rats, found the parts of the brain affected by addiction. But then in 1994, Doctors Volkoff and Shelbert, top neuroscientists, ran PET scans of the brain that showed the effects of substance use disorders. And like other diseases, these scans showed it affected tissue function. So there are 2 main parts of the brain affected by drug use: the limbic system and the cortex. The limbic system, located deep within the brain, is responsible for our basic survival instincts. So when you do essential things to stay alive, like eat, drink, find shelter, have sex, or care for your young, your brain reinforces behaviors that cause the release of dopamine from this region. That reward for surviving is also transmitted to the amygdala and hippocampus, which records a memory of that feeling, so we seek it again. This is our survival hardwiring. Addiction also affects this area, up here. That's the prefrontal cortex, which is what separates us from other animals. And this is where decision-making and impulse control live. When drugs or alcohol are used, they activate the very same dopamine process in the survival center. And when use is repeated, that substance can hijack that part of the brain. This hijacker changes the brain and weakens this system to make it believe that the primary need for survival is the drug. In hijacking the brain, it can usurp those primary motivations: food, water, shelter, sex, and protecting our young. And the hijacker needs more and more of the substance to activate the same level of reward or feeling of pleasure, causing the brain tissue to become increasingly damaged with continued drug use. So why don't all people who use alcohol or drugs become addicted? There are factors that contribute to the development of a substance use disorder. They include individual factors like your genes, your age of exposure, and then environmental factors like drug availability. But there is good news. Addiction is preventable. Key factors that aid in preventing addiction can be categorized into 2 parts: risk factors and protective factors. Protective factors range from parental involvement, programs that improve self-control, limiting availability, and increasing attachment to your community. Another key element in preventing substance use disorders is to delay when use begins. Put simply, prevention is about delaying the onset of first use. In the adolescent brain, where brain tissue is more vulnerable, the hijacker is more prone to weaken the brain and plant itself as a disease. Those with substance use disorders commonly initiate first use much earlier, between 12 and 18 years old, which increases the likelihood of the hijacker taking hold. But if the hijacker does take hold, addiction is treatable. Advancements have been made in assessments, treatment programs, recovery supports, and medications to treat addiction. Brain scans show that once in recovery, the tissue in the limbic system and cortex can get better. With your help, we can expand these innovations to help millions of individuals and families and ensure that addiction is treated as the medical issue that it is. Together, we can solve this. Join us.
I always just think that video does such a great job of kind of breaking this down, right, to some of the basics. So, right, the video talked about 2 parts of the brain that are most significantly impacted with addiction. One being the limbic system, which lives within the old brain, and it's kind of like at the back of our head, where our head kind of guts out. It's right, developed earlier. It's where all of our physiological functions that allow us to survive and be alive are located. It is also, I think, what I always want to remember about the old brain is that this is a part of the brain we have really no control over consciously. And in case you're thinking, well, wait a minute, emotions are there. I can control what I do when I'm angry. True. But the initial feeling of anger or fear, right, are things that we don't necessarily, right, consciously control. So, and all of these basic emotions, when you look at them, what I always remember about these particular emotions is in one way or another, they are connected to survival, right? So, and this is also the part of the brain in the limbic system where our brain really imprints survival memories, right? So, right, first and foremost, as a species, as human beings, survival of our species comes first. And that's the same for any other species. So we can kind of think about this as the kind of the go, right? The reactive part of the brain. So, and the video does a really nice job of the way it talks about, right, the limbic system and the way that dopamine works within the brain, that it really is the signal that drives us to repeat certain kinds of behaviors, and it drives us to repeat the things that are necessary for our species to survive. But addiction also impacts the cortex or the prefrontal cortex. I always put my hand on my forehead because it lives like right behind my forehead. This is really the last part of our brain to fully mature. It doesn't fully mature until about the age of 25. So if you have adolescents at home and you look at some of these functions, you're like, oh yeah, they're not that great at this stuff. What I want you to know, and I think this is the piece that gets far less attention around addiction, is addiction impacts the prefrontal cortex. Now, again, remember, right, we want to separate the disease of addiction from simply using substances. Right, we're talking about a brain that has undergone some specific changes, and I list them here in just a minute. That right again, the language that I keep using is when the brain becomes an addicted brain. So the brain that's undergone those changes, we have a prefrontal cortex that's compromised. It's not that it's not functioning at all, but it's not functioning anything close to optimally. And when you look at what it does, right? We look here, this is where our judgment lives, our impulse control, self-monitoring, right? The ability to organize and sequence our thinking, the ability to learn from experience. And we talk about, well, why do folks keep repeating the same things over and over again? Why are they not putting the pieces together? How is it that they don't see that the way they're using substances is impacting their life so negatively? That ability to see that and understand that and do something about that really all lives in the prefrontal cortex. And I think for me, this is one of the things that is the hardest thing to wrap my head around, is that how is it that this executive and coping functions and problem solving part of my brain isn't operating the way that I want it to, because that's the part of my brain that I feel so in control of. But we see it over and over again in the way that someone's behavior is. And I'll unpack that a little bit more here in just a minute. And I'll circle back to this slide again because it has some significant implications. Dopamine is a neurotransmitter, but I also hear the term neuromodulator used with dopamine and being said that that's a more accurate term. And we always hear it called like the reward center of the brain, but it's also right, the reward motivation center. So it's what drives, right, primary motivations. And the video talked about some of those primary motivations, one of which is caring for our children. Right, dopamine drives our primary motivations that are necessary for our species to survive. And so the brain itself will drive us to repeat the things it perceives as life sustaining. So if you've ever found yourself with your hand in a bag of potato chips that you intended not to eat, and all of a sudden there you are and you don't know how you got there, you can thank dopamine. Because a lot of those foods, right, give a pretty powerful dopamine response in your brain as well. Not as to the same degree as substances, but not to the same degree as broccoli either. So what happens is, right, over time, as the brain is regularly, right, flooded with dopamine, it will, if it has the vulnerabilities, and this is not every brain, right? So brain that is more vulnerable to the changes that are inherent to addiction will undergo these kinds of changes. It's going to produce less dopamine, and it's an attempt to try and achieve, right, homeostasis or balance. There's such a huge flow to dopamine in the brain from the substance use. The brain produces less on its own, it also prunes back dopamine receptors. What that means for the individual in active addiction, when the brain's undergone these changes, their ability to experience that normal reward or normal motivation is reduced significantly. That also means their ability to experience joy is reduced significantly. And we do see, right? We see this in folks in active addiction. We also see this in folks in recovery. One of the things I want you to hold on to is it can take up to a 24-month period for the brain to recalibrate or quote heal. Recalibration is a more accurate term, but heal seems to be one that really resonates for us a little bit better. When the brain has become an addicted brain, using substances is not fun. It's not a party. It's not anything really enjoyable any longer. It really is about trying to get dopamine back to a normal level. There is such a significant negative emotional state in the absence of substances once the brain's undergone these changes that I think the best I can tell you from lived experience is that it felt intolerable. I don't know that there's not words that will adequately convey what that felt like. One of the things I said in a presentation last week was it was like I wanted to peel my skin off. When I was in severe active addiction and I would go for a period, maybe whatever, 12, 15 hours of not using anything. Usually I couldn't find something or I would sleep after being up for several days. When I was awake again, my insides felt like they were going 10 million miles an hour. And everything about the mess that my life was just was like a huge flood. And it is most significant negative emotional state. And in early recovery, the ability to feel joy was not there that much either. Particularly, sometimes folks have kind of a pink cloud period the first few months in recovery, and then reality kind of sets in of how much you've messed up your life. Part of why I like to really convey this idea around joy is that so frequently when we're working with parents and infants and toddlers, right, we're looking for joy in parenting. And what I want you all to remember is when you're working with folks who are in early recovery, working with folks with substance use disorder, the parts of the brain that drive joy are all compromised. So what we see oftentimes is folks that are flat, that don't experience joy. We also know that folks in active addiction produce less oxytocin, right? That neuropeptide that's responsible for those feelings of love and affiliation, that is compromised as well. And so what I always remember is, right, they're not feeling the feels. If you're working with folks and you're thinking about, I'm trying to assess, right, maternal bonding. And I think that the same can be true for fathers. We just seem to, in our field, work far more often, frequently with mothers than we do with fathers. But if we're looking for joy as the barometer of bonding, we would be doing the folks with substance use disorder and folks in early recovery a real disservice, because the neurobiological drivers of those emotions are not online yet, and they're not working well. It's important, and in the next session this morning, we'll talk a little bit about, right, having conversations with families. It's important for parents to understand this, because what I find, and certainly what I experienced myself, was what I knew I should be feeling, I wasn't feeling. And I've had done enough work with parents and talked with them about it that I know that this is the case over and over and over again. And folks think there's something horribly wrong with them. And don't forget the information that the way the brain's been impacted by addiction, what they expect or what they want to feel, but that they will feel it. And so it allows us to have conversations with folks around how do we go through the motions when we're not feeling the feels? Because what baby needs is for us to go through the motions. And the cool thing is that's also really helpful for the brain, and for the brain to doing its recalibration and healing. But then, right, just toggling back to the brain changes, right? Less dopamine, fewer dopamine receptors. The brain has come to believe substances are necessary for survival. So it is driving that use of substances, and at the same time, in the prefrontal cortex, which would be the place that would go, this is not a good idea. Try to hold off on this. Right? The voice of reason, that's compromised as well. So, and I know I have let's talk, but I have some other things I want to share with you before. I'm going to try and get through them a little bit more quickly here. But these functions are not right online or working well. There are some significant implications, right, for our work in home visiting and early intervention as a result of this, right, with folks in recovery. We really, really, really want to be very intentional about not just teaching things by just talking. We want to, and I think in our work all the way around, but it's particularly really valuable for this population, we want folks to learn in real time through experiencing things with their baby. We need to set up experiences. And then really use that real-time experience to convey concepts. So for example, let's say I'm wanting to help somebody understand about how you as a parent will know that your baby is feeling overwhelmed. I can talk all day long about gaze aversion, right? With a new baby, and they're gonna turn their head and gaze avert when they are overstimulated and have had too much. But what I always want to do in something like that is, rather than just talk about it, I want to facilitate an experience where maybe me and the parent together would be like, let's see how your baby tells us when they've had too much, and I'll have them get a rattle or whatever. And of course, we want our timing needs to be good for baby on baby's timetable. This doesn't work with a hungry baby, or so on and so forth, but y'all know that. And together, I'm going to be with the parent. I'm like, okay, shake the rattle and let's watch for when she tells us she needs a break. Here's what we're looking for. We're looking for her to turn her head. She may just turn her eyes. Let's watch for when we see it. And then I have the parent shake the rattle. I do not model it. They need to be doing it. They need to be doing it. And usually I will see it in the baby before they do. And the hardest part in the world, as you all know, is restraint and me keeping my mouth shut and giving the parent the space to put the pieces together. I want their brain to do the thinking, right? Why does that matter? I want to strengthen the neural pathways into the prefrontal cortex. When I do things experientially and I can put those pieces together and support them in that, it allows that to happen in a much more robust way. Tell me, Suzanne, EF disorder, because I'm missing that acronym. So, that, what, I don't know the answer to that question. That's a really good one. That's going to be one of the, if it's executive function, and we think about, someone with traumatic brain injury, and so on. And I don't know the answer to that. It's not an area that I've dug into significantly. So I wish I could help you with that, but I can't. I want to talk, and I just have about 3 minutes, so we're going to get the Reader's Digest version of this. Is we in the video mentions this about caregiving. The reward system is also responsible for driving early caregiving behavior, right? So we know this one. It's connected to human survival. Human infants don't survive without an adult caregiver. So we also know, we're working with folks who have, and I think about the motivation system in the brain, and what are the most salient or most important cues, to the brain. And for a person who is in active addiction, the most salient cue to the brain is the substance. For most other folks where this isn't a factor, we have a new baby, the most salient cue is the baby. So I always like to think about that and this is particularly true, for folks both in active addiction, but also in early recovery, that that there's competition, right, in the reward center for what's most important, the baby versus the substance. And one of the very coolest things about early recovery and folks who've had a baby, right, there's a lot of challenges and they're navigating massive, massive changes, I think, in a parallel kind of way. But as we help parents connect with and build relationship with the baby, that investment in the baby helps to reset the reward center. To me, that is just like next level amazing, and a huge benefit in, I don't want to think about the baby as a resource, but like a resource to help somebody in supporting their recovery. Now, folks you're working with in recovery are going to have other people in their life that is going to tell them, focus on your recovery and put parenting second. You'll have time for that later. I train addiction folks on this same stuff again and again and again because I'm like trying to reroute them. Because the reality is being engaged with the baby is a huge benefit neurobiologically and for parents. And I don't care how many times parents get told, focus on your recovery and put your baby second. Nobody wants to do that. But people quit seeking support around the parenting within the addiction world because they get that message, right, too frequently. So this, right, brain pathways overlap. At the same time, this is also a population that has a stress response system that is pretty much in overdrive. So, right, it makes it right more difficult. They are really, really stress sensitive. And that's from a physiological perspective. Folks who've had opioid use disorder will experience that more at a greater level of impact because opioids just are really unbelievably effective at eliminating stress. And part of recovery and kind of coming out the other side of it is some of the things that the substances did. It's like a pendulum swings too much in the opposite direction. What I also want you know, a couple little tidbits too, I think that are really important. Medication for opioid use disorder for folks that you're working with who maybe be on methadone or buprenorphine. All of the brain changes and the ability for the brain to recalibrate exists for folks that are on medications. Medications do a really good job of stabilizing brain function. They are not a barrier to engaging with babies or to parenting. And as challenging as some of this is in early recovery, none of it is impossible. So I will leave you kind of with that. Ultimately, I feel like, right, connectedness is a part of the key to all of this, that's our superpower. The work that we do, the relationships that we build and working with families and engaging in real time is huge. And there's a lot of resources for that, right? If you're in home visiting, depending on the parenting curriculum you're using, Parents as Teachers has lots of great stuff in it. If you're using Growing Great Kids, there's tons of stuff in there. Early intervention, I know everything y'all do is all in real time. And we're supporting parents in that way. And just know that when you're doing those things, you are supporting their recovery. And using a substance in and of itself does not mean that babies are unsafe. They are connected, but they're also separate issues. So this is a QR code. We would so appreciate if you just take a few minutes, maybe even only one is all it takes. It'll take you to a survey. Like you all, right, we are funded ultimately through the federal government, which means, right, we have to do evaluations and turn in different kinds of things. That helps with our funding. And it also helps us know how we can improve what we do. So that's the QR code for that. And then we're going to do another session focused on stigma and implicit bias, and also touch on having conversations with families, because that feels really hard lots of times for us in the work that we're doing. hopefully folks have had a chance to hit that QR code. I think that I can pop it into the chat too. Let me stop sharing. It wouldn't let me put it in the chat. I don't.
Hi,
Oh,
everyone.
there it is. Yay.
Did you get it, Sharon?
Yeah, it wouldn't let me. At first it
Great.
wouldn't. Yeah.
Great.
Second.
So yeah, if you all could just take a moment to complete. So this is part one. This is the feedback for Sharon and the Opioid Response Network for this part one of our substance use disorders workshop.
Welcome back, everyone, as we all get settled back into our chairs for the second part of our presentation today. I just wanted to take a moment to introduce myself. I'm Lisa Denny. I'm the Workforce Development Manager over training and coaching at Early Impact Virginia. For those who don't know, Early Impact Virginia's mission is to advance and accelerate the equitable and sustainable growth of maternal, infant, and early childhood home visiting in Virginia. We believe that all children grow up healthy, loved, and ready to learn in thriving families and strong, supportive communities. And we deliver this mission and our vision through our training, coaching, continuous quality improvement, research and data collection, and as the state leader in Virginia over early childhood home visiting. So I'm sure as you guys have been listening to Sharon for our first part this morning, you've started thinking about families that you work with who have been challenged with substance use and addiction. And I hope our second part for this morning will give you some more guidance and support as you work with these families as they face the challenges they may be experiencing, just in the challenges in raising children, because we all know that children don't come with instruction manuals. And as we continue to work with families, helping support them through the new phase of life in having a child. So I'm going to turn it back over to Sharon. And please, as Lorelei mentioned, if you have questions, please put them in the Q&A so that we can make sure that they are posed to Sharon throughout the second half of our time together. But we look forward to the rest of your presentation. Sharon, thank you very much and take it away.
Thanks, Lisa. So appreciate it. I love all the things I hear about what's going on in Virginia. I was, when I was looking in the chat here, right, from earlier about, right, real-time experiences. And I'm glad that it shows up in the chat, right, as a big takeaway, because it is really so huge. I think it's huge for everybody. I was a in-state trainer and actually a national trainer for the Growing Great Kids curriculum, if anybody is familiar with that. And I feel like learned so much about the value of real-time experience for all parents. And I think it's particularly valuable for families with substance use disorder, because how folks are coming into, in fact, families in early recovery, because of the challenges that they are facing, right, with that prefrontal cortex. So part of what I always want us to think about is one of the big takeaways for me from that is how do I find that balance of, right, not doing things for folks that, right, that they could do for themselves. We all get, right, I always say, get taught that in social worker school. Don't do things for people that they are capable of doing for themselves. We learn that in home visiting. We learn that in early intervention, right? Our goal is in empowering families. One of my big rules of thumb when I'm working with folks in early recovery is I kind of think about what level of support would I provide a 15-year-old. That's not to say folks in early recovery are like 15 years old, but sometimes their executive functioning is similar. And so it's an easy barometer. And then I really pay attention to them, right? And what are they showing me and how are they growing and how is that looking and where do they need support? But I really do, value real-time experience. I think one of the things as a home visitor that I had been taught over and over again is model for parents, right? Model for parents and they'll do what they do. At one point in time, I think this was probably in the early 2000s, 0 to 3 did a pretty good survey with families and around modeling. And parents didn't realize we were modeling, y'all. They just thought we were playing with their babies. So if I'm modeling, I want to model with coaching and and now you give it a try, right? We want to do it together. And sometimes I also know that I don't want my modeling look too good, right? I don't want someone to feel like, oh, I could never measure up to that. Parents are so worried, and parents with substance use are always feeling like they are so less than. And they hold that feeling for a very, very long period of time. So, one of the biggest challenges for folks in recovery and around parenting is fully understanding the baby's emotional experience, because it's driven by multiple things, one of which being is our executive functioning, right? Our prefrontal cortex is where empathy lives. It's also driven through our own earliest caregiving experiences as far as our own capacity for understanding the emotional experience of another. So, right, that real time really matters. And I was also glad to see someone write in here about restraint. I think that's one of the hardest things ever, is to keep my mouth shut when I'm seeing something, to give enough space for the parent to see it too. I always remember my ability to open my mouth does not go away, but I can wait. So I'll just leave that with you, and then I'll jump into, right, this presentation, and we're going to, let's see here, my slide where I want it to be. This is a quote from Michael Botticelli, who at one point in time, under the Obama administration, was the director of the Office of National Drug Control Policy. He's also a person in long-term recovery, and was at the first person at the level of government that he was in to ever be open about their recovery status. And part of why I spend the time I do on the brain in that last presentation is around this first sentence, right? The public at large has viewed and continues to view addiction as simply a matter of individual choice. And so my hope is always, by understanding how the brain is impacted by this disease, we start to see how that those brain changes can remove the true power of real choice. And families, we're both in active addiction, but families who are on this recovery journey really, really, really need the things that you all offer, right? If their children are experiencing developmental challenges, which many of them may, they benefit immensely from early intervention services. When it comes to promoting and strengthening the parent-child relationship, I know nobody does it better than the programs that you all work with. I mean, that's what our home visiting programs are all about for all families, right? Is strengthening the parent-child relationship. And when I learned how key that is to strengthening recovery, and what I think is parenting is recovery and recovery is parenting. They are not separate, and they're not separate neurobiologically. They're not separate in an individual's day-to-day experience. But what I also know is that stigma, right? Feeling like folks maybe aren't the greatest parents in the world, that the way that they use is a matter of choice, or so on and so forth. What I know is that the more we reduce stigma, the more likely it is that families will let us in the door. And what I always remember, and what I know from my own lived experience, is living in active addiction, folks don't survive it unless they have really good intuition. So sometimes we think that we can fake it, right? We think that, well, I really think like their parenting is not up to par. They're just out partying and having a great time and not doing right by their baby. But I can still show up in their house in a non-judgmental way. They won't know that that's what I really believe. And part of what I always want to say is, don't underestimate them. They know. And they don't let us back in, because when we have some stigma, which I always think that having some stigma is normal, It's not makes people, doesn't make someone a bad person, bad at what they do, or any of those things. It's normal, right? For most of us, we're trying to work with folks who are experiencing something that we've never experienced that looks pretty confusing. And I know from living it, as much as I train around addiction, the science, and all of those pieces, I will also say, sometimes in the space of 10 minutes of talking about the brain disease, I will say, and I should have been able to do it differently. I should have shown up for that basketball game. I should have shown up as a parent. I should have, my daughter deserved more. And so I know if when I sometimes will come that way, and I've lived it and I train it and all of that, right? Stigmas within what's typical. And at the same time, coming to trainings like this and really kind of working within ourselves, working within supervision when it's showing up in ways that are harder for us to navigate, is really key for families, allowing us to continue to come back. Because when we're encountering stigma, it really activates that feeling of shame. And the one thing I know about shame is it's intolerable. And for folks in early recovery who are no longer using substances to tolerate life, but don't yet always have navigated all the skills, right? I rarely feel shame anymore. I'm 20 years in recovery and I've worked out a lot of stuff. But that's not to say it never pops up. There's a couple people in my life, they might be family members who can activate it, but not all the time anymore. So it's pretty powerful. So right in this particular section, we're going to talk about what stigma is, and how stigma in general, right, impacts individuals who are experiencing addiction as well as those in recovery. We're going to talk a little bit about implicit bias, and we'll learn some strategies about, right, taking a look at our own unconscious bias to think about where, right, that may come from and what influences us. I'm going to talk a little bit about language, and I've got some slides that have some do's and don'ts around language. So you'll have an opportunity to download the PowerPoint handout. So that's always a really helpful thing to start to shift our language, think about what we can all do. And then I also want to think about, right, how do we end up, right, how do we have some conversations with families? So, right, with stigma and discrimination, I always say, right, to tame it, right, we have to name it. As this opioid epidemic was beginning, Obama was our president and said, we can't fight this epidemic without removing stigma, which would be true. When you think about, right, what it is, right, it's when we're socially, right, discrediting folks and we really feel like they are to blame, right? And that they have more control over their behavior than they do. So there's two main factors, right? Cause and controllability. Interestingly, right, I'll hear people talk about, they'll be like, well, they made a choice. They made a choice. They made a choice when they used substances. True, very true. I began using substances at the age of 13. It was certainly a choice. At some point in time along that road, my brain underwent some changes where in a lot of ways that power of choice was removed. And that is what addiction is. And I think about, I also have cardiovascular disease because I have a family history of that as well. I haven't always been a person who ate healthy. So my own actions and behaviors contributed to my cardiovascular disease combined with genetics and epigenetics and all of those things. But no one will ever look at me and say it's my fault that I have cardiovascular disease, probably other than me. But when it comes to addiction, and particularly as a parent and even more specifically as a mother, folks will look at it as your fault. And I think even more importantly, as an individual who's experiencing it, you look at it as being your fault, right? So why is it so damaging, right? It becomes a barrier to folks getting supports and services that they need to change their lives, to become well, right? It's a major reason why folks with substance use disorder avoid getting care, right? They either delay getting care or avoid getting care because they don't want to be one of those people. And the things that influence stigma really, right, are all around us. It gets in the way of evidence-based compassionate public policy. So part of what I talked about in that last presentation with that timeline and the lack of ongoing recovery support services for folks, that's related to stigma as well. And I'll give you a really great example, right? A lot of counties across our country have a lot of dollars through the opioid settlement. Now, I live in South Central rural Kentucky, and I was about 6 months ago outside at a bonfire that I'm talking with this woman who, as it turns out, is the person in charge of deciding what the county I live in, Pulaski County, Kentucky, is going to do with opioid settlement dollars. And because of the data here, they got millions upon millions of dollars. And what she said was, well, I know what we're not going to do. And she named off a number of things, right? Access to medication, supporting people in recovery housing, like a lot of things that have a very strong evidence base. And she goes, we're not doing that stuff because we're not rewarding those people for that bad behavior. And what I want to do is more DARE program. I'll have you all know, in case you don't know, right? The DARE program, the evidence base is terrible. It actually is detrimental. She goes, because I want to help kids. Just say no. And what I thought about is in rural counties, and maybe not so rural counties all over the country, folks are making decisions about dollars, and stigma is driving their decision making. And as a result, folks aren't going to get some of what they could benefit from. So it frustrates some evidence-based and compassionate public policy that could really make a difference for folks. And it continues to have an impact on the quality of care. So if we think about it in relationship to other things, just imagine, y'all, you went to the hospital, you had chest pain, right? And they find out you're having a heart attack. And so you're in the emergency room and they're like, yeah, we're going to get you stable. Here is the number for some places that you can go for cardiac catheterization and some further testing around your heart. But just so you know, they all got a waiting list and they're not, you're on Medicaid. So yeah, they may or may not. There's very few places that'll take Medicaid that can help you. But, good luck, because you did this to yourself. You ate too many bacon double cheeseburgers, and because of your choices, this is your fault. And by the way, there is medication, aspirin, that can help you, but we're not going to give that to you unless you show us by going to counseling and eating healthy for 3 months that you're really serious about this. So we're not going to give that medicine to you. You have to do certain things first. And then let's say, those bacon double cheeseburgers are calling you because you've seen a million ads and those golden arches are everywhere. And you end up back in the hospital for chest pain again and they kick you out. Now, we would never, ever in a million years address a heart attack, cardiovascular disease in this way. But every single day across this country in emergency rooms, this is exactly how we address a substance use disorder. We have medication called Narcan, which most folks, I'm guessing most of you have heard of, right? That will reverse an overdose. And we have first responders in some communities that refuse to use it because those folks are just going to go back out and do that again. So stigma shows up, in so many, different kinds of ways. And it has a way, of intersecting, with other kinds of bias and stigma. So I want to talk really specifically around opioid use, stigma, and how it, impacts folks who are pregnant, There's a lot of stigma specific to folks who are pregnant who have a substance use disorder. And the way that I say it, when someone who has a substance use disorder becomes pregnant, we focus tremendously on the use of substances during pregnancy. Hospitals across the country toxicology test women in labor meconium, cord blood. When those things, without informed consent, when those things are positive, then there is a report that's made to child welfare. That's pretty routine practice in most hospitals across the country. We don't tend to test or look at alcohol use disorder. We have some states that have criminalized the use of substances during pregnancy. Alabama being one, Tennessee for a while, Oklahoma had legislation around this, and so folks were being incarcerated for having a substance use disorder while they were pregnant. However, they were focused on certain substances. And this is where the stigma part comes in. I mean, I think it's stigma all the way around, but no one was testing for alcohol. And to this date, alcohol is the only substance where we know without a doubt there is a linear cause and effect relationship between the use of the substance and long-term permanent developmental delays, right? Alcohol use and fetal alcohol spectrum disorder is the #1 cause of preventable, quote, mental retardation in this country. We are woefully inadequately identifying it and supporting children around it. Nor are we removing children related to anybody's alcohol use during pregnancy. But what I see happening, and I see this because I train all over the country, for example, and Virginia does pretty well. State of Missouri, for example, if you are on medication for opioid use disorder, either methadone or buprenorphine, they are going to open a case with child welfare simply based on that when you have a baby. And they are frequently going to require you to discontinue the medication that is saving your life to retain custody of your children. And that's related to stigma. So I trained in Missouri, and I had a peer support in my training. She had to keep leaving and coming back and leaving. And she said, I am so sorry. She goes, I have a mom who has been on methadone maintenance for 10 years. She's stable. She decided, right? She got married. She wanted to have a family. And now that she's had her baby, the baby is positive because that's part of what's going to go along with that. And they're telling her that she has to discontinue methadone to retain custody of her child. And she is so scared, and rightly so, right? So we wouldn't do that with other kinds of medication, even if they could have an impact on the child. And so, right, again, this is where stigma plays a big role. And we have stronger evidence of harm related to some things that are legal, tobacco and alcohol particularly. There is no punitive approach there, but there's some really significant punitive policies that focus on the use of substances that tend to be illegal. And as of today, right, we don't have any really, really solid research demonstrating long-term developmental impacts from other substances. It doesn't mean we won't, but today we do not, other than, right, for alcohol. Now, and I will just for a minute, I want to make sure that I clarify some of that. One, National Institutes of Health is doing, initiated a couple of years ago, a longitudinal study called Healthy Brain and Child Development. It's a 10-year longitudinal study, and they are looking at longer term exposure and to see if there's any things related there. I will say you will find research out there that's going to say that there's long-term developmental impact from opioids, from medication for opioid use disorder, potentially from other substances. You really want to look at that limitations section of that research study, because what I see again and again, and this is what makes the research really challenging in this area, is they're not necessarily controlling for the use of other substances. So it's really hard to say, well, medication for opioid use disorder cost X, Y, and Z when the person was using a tremendous amount of alcohol in that pregnancy as well. The other thing that they frequently are not controlling for is toxic stress, adverse childhood experiences, children living in environments where there is active addiction, as well as children experiencing disruptions and multiple disruptions in their earliest relationships. And those are all things that we know have the potential to have a negative impact on child development, particularly in that child's capacity for behavioral control, which tends to be when I work with folks in early childhood education and in the early childhood arena, the thing that comes up a lot is that kids who've had exposure have a really difficult time, right, managing and regulating. And we always want to pay attention to what are their early experiences look like. Did they have a reliable, consistent regulatory partner in their caregivers? And was that a consistent, right, person or small group of people over time? I think because of the significant involvement in child welfare, we have a lot of children who end up in out-of-home placement or multiple placements that has a profound impact on their ability to regulate. So I can never get through a training without talking about that, right? Just a little bit. Stigma also has a really big impact on folks who are pregnant. One, seeking and accessing prenatal care, right, early and regularly, as well as seeking treatment. The prevailing belief among folks with substance use disorders, if I seek treatment, that increases the risk they're going to take away my baby. Now, the reality is that the opposite is true. Folks seeking treatment and having the opportunity to get stable during their pregnancy increases the likelihood that they won't lose custody of their children or child. However, that's not what the individual with the substance use disorders believes. Folks are terrified of child welfare, and as a result, don't always seek treatment. Most states, really, actually all states, are going to be toxicology testing, as I talked about, and it's driven through some federal legislation called Plan of Safe Care. That asks for notification to child welfare, but most states, their child welfare agencies can only receive a report as opposed to notification. So, right, this quote is right from a real parent, and what she says, right, I was scared coming here, and she's talking about treatment because I thought it's going to be immediate social services involvement. I thought I was never going to see my child again. I never heard of this program until the day I admitted I needed help. And that day was terrifying for me because I had no idea what was going to happen. People had told me seeking treatment would mean immediate removal. And what she says is really reflective of what many folks feel. Sometimes folks don't accept the services that you all provide because they're worried about child welfare involvement, even when they're doing really well. But they can be very critical of themselves, which also means that they're pretty sure the rest of the world is pretty critical of them as well. There's a whole added layer of stigma around medication for opioid use disorder. So, right, folks, and that's that acronym MOUD. And that really is, right, medications such as methadone or buprenorphine, which buprenorphine goes under the names that folks hear about it the most as Suboxone. Is probably the most common name. I'm not promoting brands of anything, but I think it's helpful to use the names that folks know. It's really, even within the recovering community, really stigmatized, and particularly for folks who are pregnant. For folks who are pregnant is also what the evidence overwhelmingly is that when someone with an opioid use disorder becomes pregnant, that medication is the preferred treatment and part of their treatment course. And that is the American College of Obstetricians and Gynecologists recommendation, the American Society of Addiction Medicine, and they're very clear on that. But the details of that's like a whole other kind of training. There is not always easy access to medication, to those supports and services, and there is a lot of stigma around that, and it's just elevated as well for folks who are pregnant. So implicit bias is always such an interesting thing because this is the bias that we don't know that we have, right? We're not conscious of this bias. And I think it's always important to know, like, we all have it. And so I think it's always helpful to think about, like, what is it and where does it come from, right? And it comes from the subconscious associations that we make, right, around certain things. So obviously we're talking about substance use disorder. So what impacts our, right, bias that we're not aware of? You know, we see substance use disorder depicted in the media, in movies, in books, right, in all different kinds of ways that influence our subconscious association. We also see recovery depicted in certain ways. Now, as a person in recovery, I pay a lot of attention to how recovery is depicted, particularly on in movies and TV shows and things like that. And what I will say, not just my own experience, but having a lot of people in my life over the course of the last 20 years who are in recovery, is I have not yet one time seen recovery really depicted in any kind of an accurate way on any dramatic anything. Because the way it tends to be shown on TV shows is as soon as that person in recovery's life gets a little stressful, oh my God, they return to use. And that's kind of the scenario that gets conveyed. And because all of us have watched, right, dramas, if you've watched Grey's Anatomy, now they do a better job than most, but even Grey's Anatomy, right, and they have multiple characters, major characters in that show who are in recovery. But they also, each of those characters have had periods where, you know, some dramatic things happen to them because it is a drama. And then their recovery becomes very precarious, or they lose it for a little while or whatever. So those things that we see, that we hear, news stories, all of that influence us in a way that we're not always aware of. Now, if you want to learn more about your own implicit bias, one of the greatest ways to do it is this implicit association task at Harvard. And I'm thinking, Adrian, you are on here, I believe. I can't see all the names of who all is here, but I think that you're here.
Yeah.
You might be able to find that and pop it into the chat for folks. There's all kinds of implicit bias tests that you can do on there, and learn a little bit more about your own implicit bias. Because again, right, it's the bias that we right, are not aware of. So, right, explicit bias is direct. We're aware of it. It's intentional. It doesn't mean we mean to feel that way, but we have an awareness of it. And what we're aware of, we can begin to work with, and it's a little bit more controllable because it's consciously. Implicit bias gets sometimes expressed indirectly, right? We may be more unaware of it. It's certainly not intentional, meaning that, again, it's operating below our level of awareness. It's when I went to work for the state health department in Minnesota. That was my first job back in my field as a person in recovery. I was about 3.5 years in recovery. And I bet for the first 6 months, I didn't tell anybody I was in recovery. And what my worry was is that if they knew that I was in recovery, they would be worried about trying to protect my stress level on the job. And I didn't want to be like seen as the weak link or less than or less capable than anybody else, right, on the team. I didn't want anyone to feel that they need to caretake or protect me in any kind of way. And at the same time, I also knew that having a big part of myself that I was keeping secret was in some ways really similar to when I was in active addiction and working in local public health. And I didn't want anybody to know about the way that I use substances. And that was a big secret. So eventually I did share with folks about being in recovery. By that point in time, though, I'd been working with them long enough that, I don't know if there was a lot of implicit bias, but there certainly wasn't any explicit bias. But it was also seen as something that was not okay to share more broadly, which was always interesting to me because I kind of thought, like, if I worked in the diabetes management part of this state health department and I was successfully managing diabetes, y'all would want me to tell everybody. But and again, right, that's just an illustration of kind of the stigma that exists in the world. And I think implicit bias is difficult because we don't want to see ourselves as having any bias. I think part of it is we also feel like, oh, you have bias, that makes you a bad person, that you're not being fair, you're not being non-judgmental. And bias just makes us human, right? We're human beings, and we are going to always be influenced what we've seen around us. And when it comes to substance use disorder and addiction, more often than not, right, many of us and many of you who are here have had experience with this among, right, family, friends, community members, other folks outside of, right, your work situation. And again, addiction in its active form creates a lot of chaos, and a lot of wreckage that may exist. We also know that when it comes to addiction and bias, that other forms of bias that may be race related, sex related, disability related, and so on can be compounded with addiction. And we see that come through in different kinds of policies and so on that we may see that happen. So there's an intersectionality around addiction and stigma, women, particularly and specifically, right, mothers. So we've talked a bit about the reporting. I think it's also important that we remember like that poverty and race and inequity play a role as well. We know that people of color are more likely to be reported to child welfare, and after being reported are far more likely to be investigated, to lose custody, and to not regain custody. And that's there's national data around all of that. So we start to think about, right, what do we do, right? What can we do? One is, doing some of the implicit bias tests, increasing our own awareness, participating in training like this. And then some of the things that we can do is we can think about our language and the language that we use. So there's been some really interesting research done around language. The term addict actually inspires more negative attitudes compared to the term substance use disorder, right? One of the greatest things I think that has happened in recovery advocacy is the language of, right, being in long-term recovery. If you all could even conceptualize, right, I started this morning and I shared with you that I'm in long-term recovery. You might have experienced it differently if I told you I was an addict, right? It's got a different kind of connotation, and it's far more stigmatizing. Some of the research that they did, and it's the research that's cited here, and their last slides have all of the citations for things. They used a case scenario, and same exact case scenario, although in one of those, the individual is referred to as an addict. The other one, the individual is referred to as someone with a substance use disorder. They gave these case scenarios randomized to behavioral health folks and healthcare providers. And what they were looking for from them is kind of their prognosis around this person. And what they found is a much poorer prognosis for the addict than the person with a substance use disorder, even though the only difference in the case studies was that terminology. So, and this is among folks who work in the field. So that I thought is pretty powerful stuff. So let's think about, right, some language considerations, because this is something we can all do. And our language does impact our attitudes, right? And our attitudes impact care and how we receive folks. I always love this quote from Don Koyas, who founded what's called the Wellbriety movement, a Native American approach to recovery. And right, if you want to care for something, you call it a flower. And if you want to kill something, you call it a weed. And I love the picture of the dandelions, because how many of us have been around young children who love to pick a bouquet of pretty yellow flowers and present them to people that they love. And they think they are the most beautiful flowers. And those of us who are in the lives of really young children, when presented with this beautiful bouquet, put it in water and put it on the counter and talk about the beautiful flowers. Even though there's a part of us that is going, we got to get rid of those dandelions in the yard before they, right, turn into that white puffy thing that spreads the seeds everywhere, and then we got a big problem, right? So think about, right, the difference, language, right? Back in 2013, really, some of the really exacerbation of the opioid epidemic, there was an open letter to the media. It was signed by 51 nationally recognized doctors, both medical doctors and PhD doctors. One of the things I want you all to know is a newborn is not born addicted, period. Hard stop, mic drop. It's not possible. Now, y'all work in the field you work in, so I know that you understand infant brain development. You go back to what I talked to in the last section about how the brain, when the brain becomes an addicted brain, how that brain is impacted and what the changes are, then you will also know that a newborn brain is it's not even physiologically possible for a newborn brain to undergo those kind of brain changes. Some newborns can be born with a physiologic dependence, and this is particularly true around opioids, but it's not just opioids. It could actually happen with nicotine, some antidepressants, SSRIs, other kinds of medication, benzodiazepines, things like Valium, Xanax, some of those kinds of things can also create that. But a newborn baby cannot be born addicted. It is not physiologically possible. So when they have neonatal abstinence syndrome, one, it is treatable. It is short term. The experience of NAS, we don't have research that says there's long-term adverse consequences from having experienced NAS. About half of babies with longer-term opioid exposure in utero will experience NAS. Half don't. We don't exactly know why some do and some don't. And we really want to try and stay away from this idea that infants of parents with a substance use disorder are the victims. Because when we use that language, that makes the mother the victimizer or the abuser. She's living with that anyway. And so when that becomes the language that we use, that's the attitudes that we are purveying. And that's the attitudes that are showing up at people's doors, no matter how well we think we're hiding it. And folks aren't as likely to benefit from our services because they're not always letting us back in the door again and again. So, and the media continues to present a lot of misinformation because it sells, and a lot of stigmatizing characterizations. I have actually a really good friend who's in long-term recovery who was on a billboard from the photo that was taken because she had overdosed sitting in a parking lot in her car, and her daughter was in her car seat in the back seat, and her picture was on billboards all over Kentucky and Ohio. Still shows up sometimes, even though her daughter, I think, is 12 now. I mean, doing great, and she's doing great and been in recovery for quite a long time. But that image of her impacts her, right? That impacts her and how she feels about herself as a parent. And so it can really get right in the way. So what are some things that we can do? We put people first. Now, right, in early intervention, we do so well about person first language around disabilities. We're practiced at this. Like we've been doing this and using person first language for a long time. So it's really extending that same thing around substance use disorder. We want to try and use clear and understandable language. Try and not talk in acronyms. That's one of the things I'm always having to pay attention to. And really focus on what's going well for folks. What are their strengths? And that's got to be a conscious decision every time we knock on somebody's door. For every parent, substance use disorder or not, everybody has, and I think particularly folks with substance use disorder, they got plenty of people in their life focusing on what they're not doing well. especially themselves. And if I want someone to see themselves differently, and, again, right, self-identity, a positive self-identity is one of the 5 active ingredients necessary for long-term recovery. If I want someone to see themselves differently, I need to intentionally look for what's going right, what's going well, and what their strengths are. And what I learned as a home visitor is that the baby holds the data. And if I pay attention to baby is conveying messages, right, all the time. The parents often miss those messages, right? So when I see a baby give their parent, right, that special look, they give their primary caregiver or caregivers, right, wide eyes, eyebrows up, their whole face lights up in a way with a smile that they don't do for other people. Boy, do I point that out. Have you noticed the way he looks at you? Look at his eyes, how big they are. Look at his eyebrows. Every time you talk to him, his whole face lights up. You are his everything. Have you noticed how connected he is to you? How much he values you? Because what I find is when I tell parents that, right? Or you can think of a time, I will never forget this, with a mom with about a 6-week-old. She was in a residential treatment program where she was when she was pregnant, and she got to come back to that program after delivering her baby. And I came in and she was sitting with him. He was facing her and he was cooing up a storm, y'all. Like he was like next level cooing. And I said, and it was just the most gorgeous thing. Y'all know what I'm talking about. And it makes everything inside of you feel so light and so happy because you see this gorgeous thing right between a parent and a baby. And I said to her, and this was right intentional. But what I said to her was, I was like, wow. And it was true. I said, it's been a really long time since I've seen a baby this young talk so much. You must talk to him like this all the time. Now, what you all know and what I know is we don't see a baby at 6 weeks cooing like that unless someone's been talking to them all the time and engaging with them in that way. And what I saw her do was sit up straighter, hold her head higher. She goes, oh yeah, we do this all the time. And then that got followed with the statement that just about killed me, which was, some of the staff here tell me that I'm spoiling him. Now, everything inside of me wanted to go into the whole thing about how you can't spoil a new baby. We all know this. But I did something different, which was, I'm so glad, because what I said to her was, I said, well, what do you think about that? And she goes, you can't spoil a new baby. My home visitor taught me that. She had home visiting. We have an evidence-based home visiting model here in Kentucky called HANDS, a lot like Healthy Families. And I said, wow. I said, that is so awesome. And how lucky is he to have a mom who's so invested in learning all about him because you're involved in home visiting. That's amazing. Did you know that you support his language development every time you talk to him like that? And she just like everything about her. Now I was going there to do some staff development. So I'm like, I got a heavy lift here with the staff. But what I learned that day was this was her 7th baby and she had lost custody of the other 6. This was the first time she was having a real opportunity to parent. And I was able to, by looking for what's going well and stating it specifically to her. And if some of your training involved integrated strategies, or they got a new name for it now, or if you've been trained through Healthy Families, we would call those ATPs or strategic ATPs. I want to elevate the things that I see that are going well that I want parents to notice in the future about their baby, right? So emphasize abilities. It was huge and it was powerful. And not just for her, but for me, because I'll never forget that interchange. I'll never forget that there was something simple that I said that I pointed out that made somebody feel more competent as a parent. And that's a really cool thing to get to do. So, right, how do we change this narrative aside from being strength-based and looking at what's going well, watching our language? Y'all won't do this perfectly because, it takes intention and it can be a shift. And I'm not trying to change the language that's used by the folks in recovery. It's me that I'm thinking about, because some of the language that you'll see here that's under the deficit base, you'll hear folks in recovery use all the time, and particularly folks involved in 12-step recovery. And I'm not trying to make them change their language, but as a professional and in my professional role, it's important that I change mine. So, and you'll have these slides. So you'll see, right, this as far as some of the changes. One of the biggest ones is substance abuse. Then when we say substance abuse, it sounds like child abuse, right? So when I say and, right there, I think one of my colleagues always said, he goes, he's also in long-term recovery, and he always looked like, I didn't abuse my substances. I took great care of them. I put them in special places and little special boxes and all kinds of things, which I always thought is kind of a funny statement, but it it's language we want to begin to move away from and have an awareness of. So we same thing around drug abuse. We think about misuse or harmful use. Clean and dirty gets used all the time in reference, particularly to toxicology testing. And so it's say presence of or absence of substances. You'll hear people, particularly people who are involved in Narcotics Anonymous, use the word clean or clean time. Again, I'm not trying to change their language. I'm just trying to, change my language, and yours too, right? And we even think about, medication. MAT is a term that's used frequently. It just carries a lot of stigma. And I know when people are talking about me, I much prefer that they talk about a person in recovery than refer to me as a former addict, because I like to stay in the solution and in my strengths, and that's in being a person in recovery. So, language really does, help promote recovery, and it keeps us from perpetuating negative stereotypes and biases. So, when we think about how to become a little bit more stigma-free, a couple things that are great resources. I think Debbie, when she was here, put this link in the chat. The same place, Recovery Research Institute, where Dr. John Kelly is, has within their website what's called the Addictionary. And if you go to their website, you can click on it. Like everything and anything language-wise, if you want to know that you got a word or a phrase or something and you want to be like, is this stigmatizing? You can go to the dictionary and type it in, and it'll tell you. It also has all kinds of links within it to go deeper. So if you want to go down a rabbit hole, or no, let me say it better than that. Here's a great example of shifting language. If you want to extend and deepen your learning, if you go to the dictionary, you can find lots of great things that you can look more deeply into and learn more from, because the words really do matter. We can also look at how do we do a language audit of both of our internal documents and materials that we have. So we want to be thinking about making sure that they have inclusive language, and then paying attention to ourselves in our own language. We'll catch ourselves, and to give ourselves grace when we catch ourselves and go, good job. I caught something and I'm trying to change the way that I say it. Look at me noticing something I didn't notice before, because that's how we shift. So let's talk a little bit around, talking with families, and how do we talk with families about substance use? Because this is a hard one. I think when I think about as a home visitor and working with, I get the gift of doing training with folks who work in home visiting, not as much as I would like to. I did last Friday though, and got to present at our statewide home visiting conference here in Kentucky, which was awesome. Talking with families around substance use can be a difficult one. And there's some things we'll talk about, what makes it hard, and why does it matter? One resource that I always love is this harm reduction toolkit, and that's where this comes from. And they're in the citations, but you also see it at the bottom, perinatal harm reduction. But they give us some great examples of, and I think this top one is one of my favorite ones around, now that you're pregnant, you need to stop smoking. We through ORN, we have a 2-day training on working with families with substance use disorder. And when we talk about pregnant and parenting families with substance use disorder, so when we talk about anticipatory guidance and education, right, you all know as well as I do that it is really tricky, and there is an art to providing education without being judgmental. And, we'll just use smoking, right, as an example, and it's the one that's on here, right? Now that you're pregnant, you need to stop smoking because we know that smoking is harmful when you're pregnant. Right? A lot of good reasons why folks need to stop or cut down. But how we say it really matters. And I do always advocate to start off by asking people, so, right, what have you heard around smoking when you're pregnant? What have you learned around smoking? What are your thoughts? Because I find when I start there, one, I get to learn where they're at, what they're thinking, what their challenges are. And it almost always opens the door to much better conversation where we can really talk about things and I don't come across as judgy. It is an art, right? How we do anticipatory guidance, which is a great public health term, and right, parenting education, all of those kinds of things, right? We talk about when we're looking at parenting things, right? Spanking is another great one, right? We can talk a lot about spanking and not spanking children and all of those kinds of things. Y'all, particularly who are in more rural areas of Virginia, at urban areas probably too, we run into some of the same stuff. I always get so much farther with conversations. What do you think? What have you heard? What are your plans? How is it for you when you were being raised? Do you want to do this or that differently? But using open-ended questions gets me so much farther. And it frequently opens the door for opportunities for me to identify and really reinforce strengths. So let's say, right, it's smoking is the thing that I'm asking about. And someone may say, and a lot of folks with the substance use disorder smoke. And I may hear from somebody that, I'm early in recovery, I just can't even think about it right now. It is just too overwhelming. What I can come back with is, right, way to go on recovery. That is huge. That's such a benefit to your child, right? Right. I may say, would you, right, be interested, since it's not, something that right now feels way bigger than what you feel like you want to navigate, would you be open to learning some things about secondhand and thirdhand smoke that will help make sure, right, that your baby stays safe, even when, right, you are smoking? Because I know it's really important to you to keep your baby safe. And so there's things that I can do there, right? I don't know that I've ever seen anyone come out and say to someone, if you loved your children, you'd stop using. But I've definitely seen us say it to each other when the folks we're serving are not in the room. I saw it a lot in Minnesota because I did a lot of staff development follow-up with our public health nurses across the country. No one knew I was in recovery, and this was early in the opioid epidemic. And I would hear all the time, if they loved their kids, they'd stop. And so what I always love with parents is, right, I know you love your children, right? I want to know what kind of parent you want to be. And someone oftentimes says, I want to be a good mom. Well, and then people tell me what that looks like to you, right? I want to know from parents, what kind of a human do you want to raise? Tell me about the qualities and characteristics you want your child to have. Let's talk about, right, how do you grow those and foster those through your interactions with them. I want to tap into and connect what I'm doing and what I'm bringing to them to their hopes and dreams for themselves as a parent and for their children. Because they know when I do that, right, I can't go wrong with them. So, right, so let's, right, talk about talking with parents around substances. Those conversations aren't going to be comfortable. And what I know is if we wait till we're comfortable to have the conversation, we'll never have it because it's not ever going to be comfortable. And walking through discomfort is how we all grow, but it's not easy. So I think that it's a skill that we gain by practicing. So one, we can initiate conversation around use of substances, I think within the broader context of a couple things. One is, and this is not where I would lead, right, is the way a person using substances get in the way of things that matter to them, of things in their life. And I think there's a difference between having conversations around with those folks that are in recovery and everybody knows they're in recovery, they know that then it makes it a lot easier. I also think that this conversation gets easier when it's something that we talk about in one way or another with every family that we work with. One of the things that we don't do routinely in many of our programs is any kind of screening. And I'm not talking about testing, right? But screening around substances using evidence-based, right, interview tools. Most folks don't have a substance use disorder, but for some folks, what screening does elevate is problematic or risky use and the ability to have conversations around how or if the way that you use substances is getting in the way of things that matter to you and what you may or may not want to do about that. And not everybody who is engaged in risky or problematic use of substances has a substance use disorder. Not everybody who's engaged in risky or problematic use needs to quit using substances completely or go to treatment. But oftentimes folks benefit from an opportunity, right, to think about and talk about the way that they use substances, and does it or does it not get in the way of things that matter to them, and then what might they want to do or try related to that. I am a huge advocate for universal screening using an evidence-based interview tool for all of our programs. And I think, I know my best understanding Nurse Family Partnership has that built into the model. At this point in time, I don't know if Healthy Families and Parents as Teachers does or not. Lisa Denny, I'm thinking you probably know that. But what I do know is prevention of child maltreatment is a federal benchmark for McV. And the number one reason that families and that children end up in out-of-home placement across this country is substance use disorder. So I advocated strongly and unsuccessfully for universal screening when I worked for the state health department in Minnesota. It may have changed since then. I've been gone from there since the very end of 2015. And I think sometimes it's easier to frame initial conversations around things that are legal. Alcohol is a great one. And it's a great one to kind of open conversations around. And we've got some societal trends around alcohol that may make it easier to do us at this point in history than it's been in the past. We see things like dry January, and I see a lot more of this on social media. People who are, quote, sober curious. I see more so today than at any other point in time, folks really thinking about alcohol use, how it impacts the brain, that it may not be the healthiest thing in the in the world for your human brain. And so oftentimes I'll be like, have you heard of any of these things? What are your thoughts around it? Do you have any friends that have been kind of trying to step away or reduce the way that they use alcohol? But the fact that it's a legal substance, at least if you're 21 or older anyway, makes it a little bit easier to have a conversation around. Illegal substances, it gets a lot more challenging because it gets combined with one, particularly families who are already involved in child welfare, and our role as mandated reporters, kind of what we do with that. And there's a lot more fear around that. I am a big advocate of being open about my discomfort. So, sometimes I'll say, in our program, we're really working to have more conversations with folks around use of substances and how that, what role they may play in their life and as parents. And I'm not totally comfortable with these conversations, but I think that they're really important because for some people, their use of substances can get in the way of things that are important to them in their life. What are your thoughts about that? or we just had some training around this. So I'm trying to explore things more with families so we can tap back into trainings. And Lisa, I see in the chat about great training, motivational interviewing, and expert. That's exactly it, right? Because really, when we think about the whole piece is in expert, right? And as Lisa typed in here with, you must have some fast typing skills, Lisa. Right, screening, brief intervention, and referral to treatment, that becomes really, right, important. And when I think about expert, just, right, it's screening, brief intervention, and I think about referral to treatment, but I tend to think about it more as referral for assessment. So, and part of why I think about it that way parallels what I think about when we do developmental screening for kids, right? When we have a child where there's a right question on a developmental screen, we're not saying the child has a developmental delay. We're saying the child needs a more in-depth assessment. And I think expert's the same. If there's something questionable on a screen and it's a positive screen for substances, what that's saying is that the individual needs a more thorough assessment. We're not saying they need treatment. We're not saying they have a substance use disorder. But that what we're saying is, right, they need a more in-depth assessment to take a more in-depth look, and that needs to be done right by behavioral health clinically trained person who is trained to do assessment. So I think that again, for us as practitioners, that parallel is really, really important. So I love expert, but I don't necessarily love the acronym. So, but I know that all of you do developmental screening. So that parallel, I think, helps us kind of think about it. And again, right, always being curious. Start with what folks think. What are their opinions? What are their perspectives? Because that's going to give us the things to anchor to. And when we know where their head is at, it's so much easier to have conversations without stepping in a mess, right? Without being stigmatizing. And it helps us, I think, stay away from the whole thing of giving a message that's right different than the one that we want to be able to give. We don't want to be giving or being perceived as being right judgmental coming from a judgmental perspective. Just right to share, I think, on the personal side of this, I will always wonder if any professional had ever had a conversation with me much earlier in my substance use progression, would things have looked different for my daughter? So I had a situation where I was actually going in for a women's reproductive health care visit. And maybe because I worked in public health, I always paid attention to that. Even as my addiction continued to progress, I was pretty diligent with that. And on this particular day, I had been actually using cocaine all day long. And I still went into that appointment in the afternoon, which in and of itself was somewhat remarkable. My blood pressure at that appointment was like, the top number was over 200. The bottom number was well into the 100s. It was unbelievably high. Like we're talking stroke risk high. No one said a thing. Nothing was said in primary care visit or reproductive health visit with my primary care provider. As I have gone back on this, and I think about one, I was probably right at that place where my disease was probably really progressing from moderate to severe on diagnostic criteria for substance use disorder. And I've always wondered, if anyone said anything to me, might we have been able to make some changes where I never ended up getting to that severe stage? Well, because what that severe stage required was leaving my home in Southern Illinois, 5 months of inpatient residential treatment, followed by 6 months of recovery housing, followed by not moving back home. And my daughter, who was in 8th grade at the time that I went to treatment, stayed with her dad. She ended up moving and living with me in Minnesota her senior year of high school, which was an amazing thing. But there were 3 years, freshman, sophomore, junior year, where I was not the primary parent. I was not the day-to-day parent. Her dad was that. And so I've always wondered, if they had said anything, would her life look different? Would there have been a way for this not to progress to where it did? Would I have been able to make some changes? And those things never happened. And so I think when we do screening and we have conversations, we give folks opportunity, right, to look at the way that they use substances or their relationship and make some changes. Let's see, Janine, a question on stigma. EA contracts use terms like substance abusing postpartum women. That would be a lovely way to, right? That would be great language to change, right? So you bring up a really good point. I think what's so cool, Janine, is right, because the training and the conversation we're having here, right, it makes us think about it, right, and how we may want to think about things differently. And it's a great example of language audit and where we might want to make changes. So I know, right, some of us are in positions to do that, and some of us, right, are not. We are all in a position when we read that language in a contract, though, to think about it differently inside of our brain. And thanks, Tracy, right? Part of why I share my story is to help us think. And to help us, right, recognize that when we're able to have conversations in non-judgmental ways, it gives folks an opportunity, right, to step back and think about their relationship with substances and would they want it to be different. I think for folks that are in recovery, right, we're talking with families who are in recovery, right, about recovery, that happens as well, because we get referrals of babies who have had neonatal abstinence syndrome into some of our systems, and the fact that, right, there was opioid exposure or parents may have been on medication for opioid use disorder, that's all right out in the open. Those I think are sometimes actually the easier conversation. So when we think about, right, how we open those conversations, and what we really want to think about is, again, the parental roles and goals, right? We want to stay away from the conversation that's not focused on the question of did someone use a substance or not, right? Use versus abstinence. It really is conversation around the parent that you want to be able to be, how that looks for you, how you want to show up for your child, and how do we support you in doing that, and how does your recovery support you in doing that, right? What does that look like for you? So, right, we want to think about, right, how do we explore recovery experiences? And in the other session, we talked about, it's a kind of a broad construct. Recovery is a lot more than whether or not someone goes to a 12-step meeting. And so when we're asking about folks around how do they support their recovery and what does that look like for them, for some folks, it will be 12-step. And how do we, part of how we know it's 12-step is they'll talk about meetings and sponsor and working steps, right? And sometimes folks in those, trying to go to meetings, it is really hard to navigate robust 12-step recovery when you have a baby, particularly when you don't have a lot of support. And especially as those babies get older and mobile. As someone said, I think in a training with a bunch of peer support, she said, when my baby was a baby and I took him to meetings with me, everybody loved him. Everybody wanted to hold him. Everybody loved him. She goes, but boy, when he got mobile, and then when he got to be a toddler, and then when he got to be, right, a toddler who's like, no, and falling out on the floor sometimes because he's mad, nobody wanted him to be there. She goes, but I still needed to be to meetings and I didn't have other people. So we want to always think about, those key ingredients that are necessary for long-term recovery that I talked about in the last session really become really valuable. So when we think about, right, how we support folks in growing their connections, how we support folks in growing more of a positive self-identity, right? What's meaning and purpose look like to them, right? What does hope look like, right, for them? And none of it, I think, is linear, right? Those things can go up and down. Folks run into a lot of different kind of barriers. And we always want to, right, dispel the myth that recovery is exclusive to what happens in the 12-step program. It may be for some individuals, but it may look really different. So we think about, right, that there's room for 12-step recovery without it being the only kind of recovery and without it being the only legitimate recovery. When SAMHSA looks at recovery, they look at 4 dimensions that really support life and recovery. And I think that this can really help us when we're working with folks. So we think about, right, do folks have a safe and stable place to live? That makes a big difference. And that's a heavy lift with some folks in and of itself, right? Do folks have opportunity to connect in community, in relationships, with social networks, right? Friendships, families? Are there people in their life that they're close to that support their recovery? Do they have opportunities to connect with other parents who are in recovery, so we're not feeling so isolated and alone? And do they have the opportunity to build community and relationships with people beyond those of us who are paid to be in their life? Because we all know folks need people who are not paid to be in their life. Just really, really valuable, right? Health, right? How are folks living with symptoms of substance use or having had a substance use disorder? And overall, what's their health and wellness right look like for them? Thank you, Julie, for sharing that too, right in there. I appreciate that. Thank you, right? And then, right, where do folks find purpose? And I think first, for many parents of really young children, part of their finding purpose is in their role as a parent, right? So how we help support them in feeling good about themselves. There's lots of places in their world that makes them feel badly about ourselves. Social media is a huge culprit on that, right? Finding right meaningful engagement. So again, this framework helps us think about recovery in a much broader perspective than just, are you going to meetings and do you have a sponsor? In fact, unless someone has said they're in 12-step, I don't even go there with folks. What I want to think about is their life and the life that they want to have and what's meaningful to them, where they find purpose, where they find community, and how we help support them in growing some of those kinds of things. So I want to pause for just a minute here and see kind of what are some of your experiences, concerns, as you listen to all this. This is kind of a, right, there's been a lot of different, right, stuff this morning. What are some of your thoughts? This isn't always the easiest venue for that, is it? Feel free to to put stuff in the chat. I want to, so, right, having these coming from early intervention services. Can you share a little more about that? If you can, Jennifer. Are you feel like for families where this has not come up at all, let's say, right, maybe someone has a baby with, right, just let's say some developmental delays and they're referred for early intervention. This is certainly not where we want to lead with, right? So that's one thing that's for sure. On our initial visits and so on, we'll stop services or feel it's too intrusive. And that, right, that may, maybe so. And I think sometimes it's for families where we've had neonatal abstinence syndrome, and that is, right, where that's a part of the picture, right? And part of why they're referred and open for services. It becomes an easier conversation. And Susanna is identifying exactly what's happening with the parent and the way that they're using, right, substances. One of the things is I think it really helps to really stay within the arena of what parenting looks like to them and how they want to show up as a parent and how do they want that to look. Because this is really really around, right, how, whether or not, or the degree to which substances can get in the way of that. So Donna's asking, right, right, infants cannot be born, quote, addicted, right? Neonatal abstinence syndrome is a completely appropriate term, right? And the other term that gets used for the same condition is neonatal opioid withdrawal syndrome, although we hear NAS a lot more frequently. NAS is a little broader. It could apply to other substances besides opioids. But it's not, right, addicted. So in the last session, I talked about, right, brain changes inherent to the disease of addiction. And there's also, right, specific diagnostic criteria. You can Google through the DSM. Newborns aren't capable of either of those things, right? A newborn brain is not capable and would not, through the in utero exposure, prune back dopamine receptors or undergo changes in a yet to be developed or connected prefrontal cortex. So, right, addiction is a term, right, that is indicative of some specific brain changes. And a newborn brain physiologically can't undergo those kind of changes. That doesn't happen through in utero exposure. Newborns who experience NAS, what they, right, they are born with they have a physiological dependence to the opioid is typically, right, and they're experiencing a withdrawal syndrome, which is treatable and manageable and short term. So that is kind of, right, dependent on, right, or with the physical dependence. And again, I think, some of the most important things around neonatal abstinence syndrome is it's typically short term. It's managed, it's treatable. The biggest struggle for the baby with NAS on a longer basis is more around regulation because they have a more difficult time filtering out external stimuli. And so when you think about, right, a baby who gets pretty dysregulated because what's going on around them is, right, too stimulating. And that happens a lot with babies in their first 3 months. All babies with NAS struggle with that considerably more. So parents need a lot more support about how do we keep the environment less stimulating. So that, right, that is true. We want to be careful. I'm going to say, right, as I'm just looking at the chat, we want to be really careful around babies with NAS have a high risk of developmental delays. We don't have solid evidence around that. Now, what I always want to think about is where we have parents with substance use disorder, we do have, right, a higher risk of parents being active in that substance use disorder. Again, we have a higher risk of an out-of-home placement. We have, right, a higher risk of disruptions in primary caregiver relationships. So all of those things create more risk for the baby. One of the great things about that just being, right, a medical risk factor in the state of Virginia that makes a baby eligible for early intervention services is the opportunity that gives us to strengthen the parent-child relationship. And again, helping to reset the reward center. And those things are a huge, huge benefit. But what I always want to think about is that the baby who's experienced NAS, as far as, right, when you think about it in this way, I'm trying to be careful in how I say this, but 50% of babies who have prolonged opioid exposure in utero, and let's just say, right, person's on medication for opioid use disorder, 50% of the babies who have that prolonged opioid exposure in utero will experience NAS. The babies that experienced NAS are probably no more likely to have long-term developmental problems than the babies who didn't experience NAS. And the only things that would really increase their risk of developmental challenges are the challenges that come along with prolonged hospital stays, parents not being able to be fully engaged with them, babies not being able to fully engage in certain ways in those earliest weeks. So it's more of those things that can put the baby right at risk. And some of those things are be similar to risk that a really extreme preemie would have with a prolonged hospital stay and parents not being able to actively caregive and parent in the same kind of way, right, in the earlier weeks. I think, again, I want to come back to I'll just, and as I'm getting close to closing, I'll present a challenge to you all. One of the greatest benefits, I'm going to move away from my slides for a moment. One of the greatest benefits for families are the kinds of services, right, that you all provide is the additional support and focus on the parent-child relationship, right? And we know that in the first 3 years of life, right, children developed in the context of relationships. We know some of the greatest benefits of early intervention is our ability to see children's potential and to help families see their child's potential. We know a lot of children who receive early intervention services that it's those services that made the difference between a lifetime of special education services and IEPs and all of that and showing up or showing up at school age in a typically developing classroom. My nephew is in college now, the perfect example. Early intervention services from the age of 7 months. And when he went to preschool in typically developing classroom. Early intervention was the absolute thing that made all the difference for his entire life trajectory. It's that powerful. Y'all know this, right? We work in this. We know how powerful all of this is. When we, as the professionals, see the exposure in utero as an automatic deficit for the child, it affects how we see that child's potential. And as the professionals in the lives of parents, when we see it that way, it increases the likelihood that they see it that way. And we still don't have super solid research that would demonstrate that that's actually accurate. It isn't automatically a deficit. I think there's things we don't know, and I think particularly around fentanyl, because it's so new and the fentanyl that's on the street is not like medical fentanyl, and God only knows what's in it. So and it's just too new. Like, we just don't know. But when it comes to other opioids, and particularly to medication, and I will say the same is going to be true with methamphetamine and cocaine, we don't automatically see long-term developmental challenges for children that are the result of the exposure. The things that increase their risk are more related to things that may happen in relationship, again, right? To parenting, to engagement, to toxic stress, and being in and out of environments with active addiction during your earliest years of life. Those are the things that tend to impact other problems. And certainly children, right, where there's been NAS because there's been addiction, are going to be at higher risk, but it's not always the exposure in and of itself, with the exception of alcohol. Alcohol is a totally different animal. We know that alcohol absolutely has the potential to lead to long-term irreversible developmental, right, challenges. I think it's the NIH, National Institutes of Health, Healthy Brain and Child Development Study continues to move forward. We're going to know more. But what I hope for all of us is that we really see, right, we focus on the potential and around the parent-child relationship, and the fact that NAS makes them categorically eligible for EI is an amazing thing, because that's not the case in most states. And that brings additional supports for families. So I think that just is absolutely huge. And it's not that you won't find research that says there's long-term developmental impacts, but read it closely and pay attention to their research methodology, and pay attention to whether they were controlling for use of other substances during pregnancy, and how well they were controlling for adverse childhood experiences and out-of-home placement, because they're not always controlling for some of those things. And we know those things have a negative impact for development. So that's my challenge to all of you in working with families. And I think one of the things I saw in the chat around in-home visiting is, we have long-term relationships with families. So by no means, when we talk about having these conversations, so I think this is necessarily what you should lead with. Everything is so much easier in the context of relationship.